Good afternoon. Welcome in Thessaloniki, welcome in ERS, welcome those brave enough against restrictions and fear and everything else. Welcome to this masterclass concerning injectables and fillers in and around the nose. There is an increasing demand on the part of our patients, and also that means an increasing interest from your part. That's why we're so many here in this class. And we have to welcome Alwyn de Souza, who had a great job preparing this event. You have to see his email. He's done a lot of job from London before coming here. But also here, he was 2 hours earlier in order to prepare the cadaver. Don't forget, we're talking about something non-surgical, but actually, it's for surgeons. It has complications, although it's bloodless. So, we have to start from the beginning because for most of us, during our training, we didn't have the opportunity to learn about fillers and injectable materials. So that's a good opportunity for all of us. And he's going to start from the basics, from anatomy to practice, and from there to complications. And every question you wish to ask at the end of his presentation, you're welcome to ask him, okay? Bye-bye. Alwyn, go on.
Thank you very much for that kind introduction, and thank you to Yanis for inviting me and the organizers for this. It's been a great honor to be here. So what I'm going to talk about in the next about 1 to 1 hour, 20 minutes possibly, hopefully keep you all awake, but mainly how do we approach botulinum toxins and fillers around the nose. Why do I want to talk about this? The main reason is I'm basically an ENT surgeon. I then trained in facial plastic surgery, so all the work I do right now is just purely facial plastics, which is just not rhinoplasty. I think there's a general misconception that if you do rhinoplasty, you become a facial plastic surgeon, and you don't. From my point of view, if you're going to do a full gamut of facial plastic surgery, you should start off with very simple things like botulinum toxins and fillers. And you will probably find that one of the things I find, certainly in the UK, certainly in London, and I think it's most of the countries is the same, a lot of people who are hardly medically trained will actually do these procedures. And I think part of the reason for that is that we have to blame ourselves for this because we actually don't take enough interest in it. And they are easy to do, they are easy to learn, and actually, generally speaking, I can tell you, you will be much happier, I think, doing these because they actually, you see some very nice satisfied patients. So I'm just going to, hopefully I'll press the right button. Why do it? Because obviously, the increase is, it is exponential. And I can tell you since COVID time, the increase in the use of botulinum toxin and fillers has gone up to a significant level. So it's not something that will go away, it'll only get more and more, and the patients will come to you. And I think I often find it very hard when people approach their doctors and ask them, where can I get my lines fixed, where can I get some non-surgical treatment to look better? We don't have an answer to them unless you know about these things. So as a very basic rule, I just wanted to remember that if you divide the face into 2 areas, and that blue line goes to the infraorbital margin, anything below that as a beginner you want to tackle with fillers, anything above that you need to tackle with botulinum toxins. Now, the most important thing to remember, of course, is, in this masterclass, I'm actually going to give you certain basic principles. Of course, you need to know a little bit about how these things work and generally understand the whole topic a little bit better. And we run a lot of, nice courses that if you at some stage want to attend, you're more than welcome. So the most common thing that I find is patients coming and looking at their wrinkling. And there is no one who doesn't see these wrinkles, and it's more now, with Zooms and things like that. And these wrinkles are formed by muscular activity. To treat them, obviously you need to know what these muscles are, what the muscles are doing. So the format is going to be, I'm going to basically go through some of the basics of this now, and then I'm going to show you some slides and also some cadaveric dissection that I've done, just to give you some idea, how these things work. So In an aging forehead, you have these oblique, transverse, and vertical lines. And basically, what happens is these are formed as a result of certain muscles. So let's look at the forehead lines in the first place. So the forehead lines are formed as a result of activity of frontalis muscle. And why do we get forehead lines as we get older? The reason is simple. The brows come down a little bit, and we tend to raise our brows to actually read and things like that. And even when we are speaking, as we get older, we raise our brows more. So the frontalis causes the forehead lines. There are various patterns of frontalis muscle, which I've shown there. But one important thing that I already said is that we use the frontalis muscle to raise the brows. So what happens is when you raise the brows, you're using the frontalis. Now, if you put botulinum toxin in that muscle to actually paralyze that muscle to some degree or weaken it, your brows are going to come down a little bit, okay? So when you're doing botulinum toxins, you've got to try and account for that. So to do that, you need to understand what are the muscles that pull the brows down that are, actually generally opposed by frontalis. And then that are these muscles. That is, the most important muscle here is the procerus. And as a general rule, if you draw a line across the, upper, the brows, so any muscle that moves, or in other words, located below that brow, is the muscle that pulls the brows down. And frontalis is above the brow, and that pulls the muscle up. So it's one simple way of remembering it. So what happens is we do use botulinum toxins, and those numbers you see are the units of toxins that I use. Now, there is a very variable rule. In men, you need a lot more than that. In women, you need less. If somebody has thicker muscles, they need more. So, but it's just for you to basically understand. So what happens is when you put botulinum toxin in those muscles, you're getting rid of those kind of wrinkling, getting a nice result. So the other thing that people ask often is they get this, sort of wrinkling around the eyes. And this is the action of orbicularis oculi muscle. And those wrinkles are what we call as crow's feet in loose terms. So that is a result of orbicularis muscle. Now, orbicularis is a circular muscle that actually helps us close the eye. And when, particularly as we get older, we try to close the eyes, and when the weather is bright, you try and close the eyes, and then you get more and more wrinkling. How do we deal with it? We deal with it by putting some amount of botulinum toxin in the areas where I've shown there. Now, I've kind of written there, avoid that area, and I will show this to you on the cadaver when I do show you the dissection. That area is where your zygomaticus major and minor muscles are attached, okay? And if you don't know the action of zygomaticus minor and major, what they do really is they pull the corner of the mouth up, so when you smile, the angle of the mouth goes up. And so if you go and inject it in those areas, in other words, if you inject it in the wrong place, then you will get a droopy corner of the mouth. So just, think about that when you're injecting it. And one of the most common things my patients ask me is that, can you give me a little brow lift? And, people like that little, tiny amount of brow lift. Of course, it needs to be done properly. If you do it badly, of course, you can get a very bad result. So, I think it's all about understanding how the muscles work, how the muscular interaction is between all the muscles, because there's always an interaction between the orbicularis oculi and the frontalis muscle. In other words, the lateral fibers of orbicularis oculi, I think I might have a pointer here. I'll try and use this. Yeah. So the lateral fibers of orbicularis oculi is the ones that pull the brows down. So if you inject laterally, you do get a brow lift. So you can get a brow lift just injecting botulinum toxin, and that brow lift is about 3 millimeters. Maximum 5, but usually about 3. But to do that, then you don't want to paralyze the frontalis here. Otherwise, what you'll find is the frontalis won't lift the muscle up, so you may not get the ideal brow lift. Now, of course, there are problems when you do this. And what is the problem? Problem is this, that if you inject in the mid-pupillary line, and if you inject very close to the brow, this is where the frontalis is pulling up, you will get a droopy brow. So just try and understand that, and hopefully by the end of this class, I would have given you some pointers as to why and how to avoid it. And when you see the actual muscular anatomy, you will understand that. Now, there are many, many variations. If you're going to inject the botulinum toxin, you need to be actually quite an artist in terms of understanding how things work. You need to take photographs, possibly even videos of patients to understand which muscles are moving. Because, it's all well and good to put it all in a slide to say these are the areas you should inject. But in fact, the muscles are very variable and how they work is very variable. So you need to think about that. There are lots of adverse effects, and I think I'm not going to go through all this because we don't have a lot of time for this, but one of the biggest problems that patients worry about and come back to you about is a droopy brow or droopy eyelid. Why does that happen? Because you've just injected in the wrong place, or you put a lot of Botox in terms of volume rather than actual concentration of the product. So in my opinion, when I inject botulinum toxin, I keep my concentration very high. And how do we keep it high? If you have 100 units of botulinum toxin, then you dilute it with only small amounts of normal saline, like 2 ml of normal saline. So, but because we are mainly talking about anatomy, I won't go into those actual doses here. Then, often what happens is you paralyze the forehead, everything works really well. Patients come back and say to you, well, I didn't have these lines before, but now you've given me these lines. And actually, it's not that you have actually put those lines there. Those lines were always there. But what the patient has done is, because we have paralyzed those and all that looks nice and smooth and shiny, they are actually thinking, these lines have to go. And that is caused by the nasalis fibers, and again, you need to understand the anatomy well here. We will go through that. And by injecting those nasalis fibers, you can get a very nice smooth kind of effect like that, where you're getting rid of the bunny lines, as we call them. So, but again, don't over-inject. We inject small amounts there. And finally, I often see patients like this who come and say to me, I've got my lip moves up to a degree, it shows my gum. Now, it's important to understand that if you're going to do something like this, just because you see the gummy show, don't try and inject Botox before you understand why it is happening. You need to understand whether this is related to the maxilla itself, whether there's a protrusion of the maxilla, whether there's a problem with patient's teeth, and what exactly is happening, because otherwise you can make this lip look a lot longer. But this is because of this very long named muscle which pulls the upper lip up. And by injecting small amount of botulinum toxin just in those areas, you can actually bring it down quite well. And patients are really happy with that. I have patients who travel from other places from quite far only for that injection, because it's a tricky injection to put in. You need to put the right amount. You need to understand what patients really wants, and you got to moderate this. The lip lines, if you are starting as a new beginner, I wouldn't advise you injecting lips, because by injecting lips you can get rid of a lot of things that happen with the lips. Some people won't be able to eat properly, some people won't be able to speak properly, but it's very, very small units that you need to put in. There's one thing that I would say to you is, I think important in injecting botulinum toxin is the volume is really, really small. So your small muscles of the hand have to be really well coordinated to have those little aliquots put in. If you're not, it's not like injecting local anesthetic whilst you're doing FES or rhinoplasty or something like that. You can't whack in 2 mils of it. You can, you just get bad results. So finally, what do we do with these kinds of patients where you have the DAO, which is a muscle that pulls a corner of the mouth down? A lot of my patients will say to me, I'm always looking sad. I'm not a sad person, but everybody says that I'm looking sad. And believe you me, I see these patients. When they walk into the clinic, I know why they're walking in, because they just look, the whole world is falling apart around them. So, and it is because of this DAO muscle. By injecting that muscle, you can push the corner of the mouth up. And mentalis, chin puckering, it can be a problem for some patients, not for everybody. And one thing that I'll say to you is that once you start injecting botulinum toxin, the upper forehead looks nice, then you move to the mid face, that looks smoother, then you have to move down. So, so you need to understand the anatomy of all these areas. And, platysmal lines, of course, whilst you're injecting platysma, all that I would say to is be very, very careful, because you need to grab the platysma and inject it, because I have seen patients, people have been injected very deep, and people have had problems in breathing, even swallowing. So particularly in thin necks, in patients who had previous problems. Now, having said all this, these things are very easy to do. If you follow certain basic principles, all of us can do it, and we can all get very good results with these. So, once we've gone past those platysmal lines, let's just look at some of the filler injections. So, what do the fillers do? So, if you look at botulinum toxins, literally paralyze the muscles or weaken the muscles to a degree, depending on how much of the toxin you're going to put in. On the other hand, something like fillers actually just fill the areas. Now, when do you do fillers and when do you do botulinum toxin? And that is a question. And I think from my point of view, as I said earlier, if you are injecting the lower face, most of the time, if somebody has got very deep grooves around their mouth, the nasolabial folds, around the chin, or they want a smoother jawline, you have to use fillers. In the upper face area, I hardly use fillers in the glabella, and the reasons for that will become obvious when I speak to you later on, because with fillers, one of the things that I would say to you is blindness is a real issue. Two things that I always worry about is blindness with fillers, and secondly, skin necrosis fillers. I see a number of patients with skin necrosis who I treat. I have had to do forehead flaps on patients, fortunately not my patients, but because my practice is almost a referral base for some of these, and you get these patients. And blindness is a real issue. So when I actually consent these patients, I consent them for blindness, and that is the first thing that I do mention to my patients, and not many people mention. So, and it is a real problem, and we'll talk about the pathophysiology of blindness with fillers in a minute. A lot of people actually come and talk to you about this, what we call as the tear trough area. This is the area. So what's happened here is you have a little bit of fat from the orbit that's prolapsing out. You have the muscles pulling down, and your mid-cheek fat is going down, and then you get this, what we call as the tear trough. Okay, that's the sort of basic anatomy of it. You don't need to know exactly what the anatomy is, but I think if you're operating for tear trough, you need to know the anatomy. But we generally fill this area. Now, you can use the fillers for this area. The fillers that I use in my practice are only temporary fillers. In other words, they're hyaluronic acid fillers. Okay, so if you look at the filler, you have the permanent fillers, which I never use. Then you have the semi-permanent fillers, and I use them in some patients. And then you have what we call as the temporary fillers. Now, temporary fillers are hyaluronic acid fillers. They last for 6 to 9 months. And the best thing about temporary fillers is if you want to get rid of the filler, you can inject hyaluronidase into the filled area, and the filler is gone within a matter of 2 to 3 hours, if not 24 hours. Okay, so it's very easy to fix. The main thing between botulinum toxin and fillers is that with Botox, if a patient gets a slightly bad result, you can say to the patient, look, I'll see you back in 3 weeks' time. Hold their hand for 3 weeks. They come back, things look better. 6 weeks' time, most of the bad effects are gone. So nobody can really sue you for that. But with fillers, you can get into real trouble. So be careful. And the number of patients that I see with problems relating to fillers, either nodules around the eyebrow or around the eyelids, or serious problems. We do have, I think, very few patients, luckily, with blindness, Far Eastern countries, where they use a lot of fillers, a lot of volume. It's a problem. So the other areas we use fillers is these lines here, and of course for cheek augmentation. Why do you have to need to know about these fillers? Even if you're a rhinoplasty surgeon, sometimes what happens, and we all have this, okay, I've been doing rhinoplasty for years and years, and I always every now and then I see a patient in whom I've done a rhinoplasty. The result is excellent, but they say, there's a small area here, I just don't like it, I have a small depression, can you do something about it? And you can surgically, if you have the experience, surgically you don't want to go in there again. So those are the patients you can put a tiny amount of filler. Now, I'm not a great fan of what I call the filler rhinoplasty, though it is something that's in the market. A lot of people do it. Why do I don't like it? Because I think people who do the filler rhinoplasty are the people who don't know how to do rhinoplasties at all. And in my opinion, I think if you don't know how to do a rhinoplasty, I don't think one should do a filler rhinoplasty, because the problems relating to filler rhinoplasty, skin necrosis and blindness are real issues. So these are the areas we can fill. And if you're going to fill this, sorry, I've gone the wrong way. If you're going to fill the for these zygomatic bones here, you got to fill that area. That's just roughly a guide. But generally, if you go from the lateral brow here, from the lateral canthus, if you go about 2 centimeters lateral and 2 centimeters below, you'll come to that point. That's where you want to fill if you want to do that. And other areas we fill are these areas here. Again, very straightforward injections. The depth of injection varies, which we will talk when we talk about the anatomy in a bit more detail. But when it comes to lip fillers, this is the important thing. And I see a lot of patients who want lip fillers, and they come and say to me, look, I'm really worried because, you see these horribly filled lips. And why does that happen? It happens because people who do lip fillers don't understand that ratio. The upper lip in Caucasians is generally smaller. It's about 1/3 the size of the lower lip. Not true in other ethnicities. So you got to look at patients. If you already have a patient who's had their lips filled, ask for some pre-filler photographs to see what their lips look like. Because when you put these lip fillers, you need to try and maintain the ratio, and don't fill it too much. If you're going to fill more than 1 ml of the hyaluronic acid filler, I think you are just putting in too much, in my opinion. So most of the filler patients, I fill only about, let's say, 0.5 ml, and you get beautiful results. They really are nice results. Important thing, if you're going to do any of the facial plastics work, please learn how to do local blocks in the face. There are some very nice papers there. You can actually block the whole face by doing the supraorbital, infraorbital, midline, incisive blocks, and you can block the whole face, and you can do the whole face treatment without actually the patient moving. And some patients don't want to have any local anesthetic. Some patients will just want to have local anesthetic creams, but I think it's something that you should know. And I think that's why I find that the dental surgeons are very good at doing that, because they're just trained how to do this. But I think every ENT surgeon should know how to do dental, blocks on the face. So that is what, that's
Very
basically what we do.
injections,
So
and,
this is a short
this is
video that
really
is just going to
fairly
give you
quick
some idea of
injections.
what we are
So you
doing
feel
here.
this a little
And
bit,
this
the
is
way
I'm
as doing
injecting
it, but
botulinum
hopefully it shouldn't
toxin.
be
This
too
is a
bad, so we're just injecting
pre-COVID
the
video.
forehead there.
So I've got gloves in only one hand now. Though I feel the control is
Doing
better
very
when I
well.
don't wear a glove in my injecting
So-
hand, because you're injecting
And
small
what you want
amounts.
to really
So what I'm
do is to
literally
inject
doing
in
is
the
injecting
areas
small
where
amount of botulinum
you feel
toxin.
there is
So
excess
that is a
muscle,
1 ml
and you have to be
syringe,
careful. What you don't want
and
to
that
do is
1 ml syringe
over-inject,
has got
uh,
50
Botox,
units of botulinum
because you
toxin,
can
because I
always
dilute
top it up.
dilute
Once
50
you
mils,
inject it, massage
50
it a
units
little
with
bit,
1 mil. Okay,
but
if you have
not too
100
much.
units of
And as you
botulinum
can
toxin.
see,
Now,
there's hardly any
again,
bleeding.
I'm talking
and,
about Botox here. I have no shares in
generally
Botox
it takes a few
whatsoever,
days for
but I
it to
think
work.
whichever
Just 2 more
product you
tiny
choose, they
ones
are
here
all
for you.
very good,
Okay,
but
just
make
one
sure
there.
that you understand how much
one
dosage
there.
and what
Okay, we're
dosage
done with
you
that.
use.
So
Now, I
I'll
use a
take the next
little
syringe.
higher
Okay, so that is the forehead that's
concentration.
done.
In other words, I
So, and as
probably
you can
use
see, the idea here is to
my
inject
dilution
very
is
small
lower
amounts in
because
small
I
areas,
tend to
so you
prefer
don't get
higher amount of Botox
total,
with a smaller volume that I inject, because I get better
totally
results
paralyzed
that way.
muscle.
And
next
once
thing
you've
is we're going to
injected it,
focus on
just
this area
massage the
here.
area.
There's
So
this
what I'm
very
doing there
small
is
muscle
I'm
called
looking
the
at the procerus
So
muscle,
what I
and that's
tend
the
to do is I
procerus
pinch
muscle,
it
and
like
you can
that
see
to
those
feel the
pro-
muscle.
now
And so we know there's the
procerus is
muscle
a deep
there,
muscle,
so we
and you
inject
see
into
how
the
deep the
muscle,
injection
okay,
needle
small
goes.
amounts,
It's not a
about,
subcutaneous
as we call it,
injection,
about
it's called a
5
deep
units,
injection.
and a small
And-
amount further
And it's a
down
32
here.
gauge needle,
And then
keep
there are 2
changing
other
it
muscles
every
here
now and
along
then,
the
30
side.
or 32 gauge, I don't use insulin needles because I find that they're quite blunt. And I think for the patient, there's nothing worse than a blunt needle. And that is injecting the corrugators there. And now, even if there's no bleeding in that area, because I've injected deep, I maintain a little bit of pressure. The reason is simple. The vascularity is quite a bit in that deep area. And what happens is, if you don't, the patient will be okay when you're injected. When they go home, they might get a little bit of bruising. And you want to try to avoid. Now, these are periocular injections. And you can see, these are literally deep dermal to, sort of almost subdermal, because there is no fat in that area. And you will see in the anatomy, there is no fat under the upper and lower eyelid skin. What does that mean? You don't want to inject into the muscle, because if you go and inject into the muscle there, then the next thing is you are likely to have the botulinum toxin going through the septum of the eyelid. And when it goes through the septum of the eyelid, what you will find is the patient will get bad results, because you have paralyzed, particularly in the upper eyelid, the levator. Again,
anatomy is absolutely crucial. You really need to understand the anatomy not to get bad results. I can tell you one thing, I don't think I've ever seen a lid ptosis or a brow ptosis or any bad results in my patients ever, simply because we know the anatomy. If you don't know the anatomy, you will make a mistake. So the next video is just going to show you some lip fillers. Now the first person you saw, I put some local anesthetic in her. Now this lady, I never use local anesthetic. She's having lip fillers. Now I don't know how she tolerates it, but she doesn't like any kind of anesthetic. It's very painful, I think, and you will see her smarting a little bit, as we are sort of going through. But you see what is happening here when I'm actually injecting, so, and again, where you inject depends on what you want to do. Do you want to expose the red lip more? In other words, you want to make the red lip bigger, or you want to make the vermilion bigger? In other words, you just want to get slightly prominent lips, or do you want to make the whole lip bigger? In my patients, if they say to me, I want these massive big lips, I tell them that's the way out, because I don't want my patients walking around with horribly done lips in particular. As you can see, you'll see as you go, okay, there's a little bit of that, as you saw. And you see that little change. It's a tiny, tiny change. Now, what I'm doing there is I'm actually injecting the vermilion, border there. There is a potential space there into which you can inject, and you can inject nicely, so you get a very nice result there. Now, if you want to expose the red lip more, you can inject the red lip, but remember that you need to warn your patient that if you expose the red lip more, they can get a little bit of dryness of the lips. So if you have patients who have very dry skin, they have dry lips, be careful when you're injecting and exposing the red lip more. They have to understand that, because otherwise, you're not going to get a nice or happy patient. You're not going to get that. And then massage it a little bit. Now, in my patients, I never actually tell them to massage once they have left the clinic. All the massaging is done before they leave the clinic by either by myself or by my fellow or by one of the nurses, but most of the time we don't need any massaging. The other thing now, that's probably the most painful injection, is the filtral column. The problem in that area is, no matter what blocks you use, you can't block the filtral column, because that area is the nerves just don't let you, because the nerve supply comes from below, from above, from everywhere, and that's the area where you can't actually get a full, but generally you can kind of hide it. The other thing is, if your patients are not in pain with your first one or two, needle jabs, then they actually feel better, then they tolerate things better, but your first jab, if they jump around, then you had it, so be very careful. Lower lip needs a little more injection. And the other thing that you will probably notice is there are many techniques of injecting, okay? And I haven't, again, put this in here because it's just too much to go through. But when I say many techniques, you can either do multiple punctures, like what I'm doing. This is what I like doing. Or you can do what we call the threading techniques. You can also use larger gauge cannulas, which a lot of aestheticians use. So what they do is they put a little bit of local anesthetic, make a tiny incision, and put this cannula, which is a large cannula, and then they inject your filler. What happens there when you do that is you get less bruising, and I understand that. But the problem with that is you are likely to inject far more than what you would have, otherwise. And that is why I don't use cannulas. That's one, reason. And secondly, there's a lot of talk about cannulas giving you less blindness. I think to me, if you're injecting properly, it shouldn't be an issue. So those are the two videos I wanted to show you. So I'm going to stop at that. So what I'm going to do is, are there any questions? Because we are going to go into the cadaver to show you what the anatomy is. So if there are any questions in the meantime, I'll take those, and we'll just give a 1-minute break or something for the questions. Anybody with any particular questions?
I want to ask something till now, from what you've heard already, or something you need to listen for this with more details. Yeah, the lady.
All right, so sorry, yes.
What is your opinion about fulfill with filler? Sometimes after rhinoplasty became worse, like deformities, small deformities. what is your opinion? Fulfill with filler these deformities?
Yeah, I think I mentioned that in my talk earlier, that if you have a very small area, you know as a surgeon, you can't fix that by surgery. I would put a filler in there. You know, it's very rare. So to give you an example, in the whole year out of the rhinoplasty that I do, I might use a filler in maybe 1 or 2 patients. You know, because if you're absolutely certain you can't fix that by surgery, then just put a small amount of the filler. But be very careful, in a surgically operated patient, the vascularity changes to a significant degree. If you look at revision rhinoplasty patients, the blood vessels are not in the places where they were before. So just be careful. But yes, I would advise use small amount of the filler. But remember, the fillers are not licensed to be used in the nose. Now that is the most important thing. So it's a off-license use, and if you're going to use it, you need to make sure that you are actually, the patient knows about it.
Would you prefer filler like an implant, thin filler?
I would use a hyaluronic acid filler. I don't like permanent fillers at all. I don't think anybody should use permanent. If there's one thing that you want to remember is please don't use any permanent fillers. They are just a menace, So, I've taken out permanent fillers in people after 10 years of fillers. So I always use hyaluronic acid fillers. What is the, as you know, there are various consistency of fillers. What sort of filler I use depends on where I use it. If it's mainly a skin problem, then I would use something like, hyaluronic acid, very fine, Restylane skin booster type of thing. But if it's, slightly bigger defect, then I might use Juvederm. So it depends on what exactly you're trying to fill. If you're not sure, then use a very thin filler, because then what happens is you can never go wrong with a thin filler for 2 reasons. One is, one of the problems with thin fillers, it's less of an issue now, is you can often see a slightly bluish area where you injected. But with your very thin, like Restylane skin boosters, you don't see that, So.
What is your advice? How long after surgery we must wait before we put some fillers?
Look, I wait for 1 year.
1 year.
I tell my patients, I say to them, look, no matter what happens, you wait for 1 year. Because I think for 2 reasons. One is, a lot of patients forget a lot of things after 1 year. And what happens is, facial plastic surgery or anything that you do on the face for people is actually understanding patient psychology, okay? Memory is very short. You can remove a big hump from a nose, and then they'll come back and say to you, oh, yeah, but this one, but no, you had a big hump. Look at your nose now. You're looking much better. So what I do is at the end of about 6 to 9 months, I will actually show patients their before and after photos, but I do not fill before 1 year. Because I think if you feel you have to go and fill within a matter of 2 to 3 months, first of all, there's a lot of edema, a lot of swelling, and secondly, I think you've just not done the right operation for the patient, So I would take a second opinion in those cases, but I would, I think I wait for 1 year as a basic rule. And I say to my patient, and I also get my patients to sign a thing even before surgery, that they have to follow my instructions. If they don't follow my instruction, as much as it's a consent form, from the patient to say that they will actually follow my instructions. So if they don't follow, they don't. So I don't do the, treatment for them. So yeah, I think you should wait for 1 year. And again, you see, it's a matter of, there might be some people who might feel early. For me, it's a matter of where do you want to put in terms of your practice. You want to be a surgeon who provides the best practice that is available, where nobody can question you about it. I think 1 year is a safe option.
What is approach would you prefer to put filler? External approach or intranasal approach?
Everything through the skin. Everything is external, because then you can see it. I mean, if you go from there, you're not going to, you're just going to cause a lot of bruising. Fillers are always through the skin, So where you see, so the other small trick that I will say to you is that if you're in that kind of situation, occasionally there are patients who will come and they will say, I just don't like that little bit of that depression, and you're not going to deal with it surgically. In these patients, I do what I call the saline test. So what I do is I take a photograph of the patient in front of them. I get a small amount of normal saline. I inject it there. I take another photograph. The patient takes the photo home. I said, come back after 1 week. If you like that effect, then we'll do the filler. So that way, the patient knows that you've done everything to provide them with the best result. Because the worst thing is to put a filler in, then if they don't like it, you got to take the filler out. So when you put the normal saline in, they see what it looks like, then they see the correction that you see. If they are not happy with that, then why do you want to even put a filler? Because if you put a filler without that, then they will come back to you and say, look, I don't like the results. Then you have to take the filler out. Then you have to, so for me, is my time wasted on the patient for a bad result, a bad outcome. So I always do that with the patients.
Thank you very much.
All right. Okay, so I think what we're going to do is go to the anatomy. So if we can project those slides there. What we're going to do is, basically I think two of us will do the anatomy together. So, briefly, how much time do we have? An hour, okay. Okay, so I'm just going to go through some of the brief anatomy as to this and why it is important. So hopefully you'll get a very good idea, and when you walk out of this room, you'll feel, oh yeah, I can start doing these techniques. Now I must say, without one of the things that I would say to you is that I'm one of the very few surgeons. I say to my trainees, learn to do this at a very, very young age, okay, when you're a trainee. Now, I know a lot of my colleagues don't like when I say that because they feel, you should be, but I think your mind should be very open. So I think these things that you should, learn at a very early stage, because, if you understand the anatomy, if you know how to inject, there is no harm in doing it, So now, the muscles we spoke about, okay, frontalis is a flat muscle, as you can see, I've put everything there, and it's the muscle, those are the sort of points where we inject, in the frontalis muscle, and what you're seeing there is the depth of the muscle is approximately 3 to 5 millimeters, if you're actually injecting. So if you're directing your needle, you're going straight down, or you can go at a slight angle. I usually stand at the head end of the patient. You can stand in front of the patient. I like the head end because then they don't see your needle and all that. And my nurse stands in front of the patient, so she's talking to the patient. It's got various fibers, and my fellow prepared this presentation for me. She did a lot of work, and I've just kind of, given you, there are variations of frontalis, okay? So I think when you look at this, you will see these variations when the patient walks in, when you're speaking to the patient. Without actually talking to the patient, when the patient comes for first sort of consultation, if they're looking very grumpy, then maybe they will be grumpy all the time. But if you crack a few jokes and they talk to you, you can see all the muscles moving, and then so those are some of the patterns that I need you to understand. And this is a little bit of anatomy. We'll go to the procedures in a minute. So let's just look at the frontalis muscles on the cadaver. So if you can switch to the actual cadaver here. So I'll just grab a pair of gloves. So we did some anatomy dissections this morning, and I think you got a backache now after the anatomy dissection. Yeah. So as you can see, now if I generally, when I see the patients, a very brief surface anatomy is that identify some bony landmarks. Why do I say that? Because a lot of patients who come to you, they would have plucked their hairs in such a way, the hairline is very high, the brows are high, you think that's where the brow is, but the bony brow is your landmark. Now, in this case, if you like, the hairy brow is down here, but actually the bony brow is here. So the first thing that I do when I see my patients is really, I actually feel for the bony brow. So I know exactly, where that bony brow is. And I actually make a note of it, in my clinic. The other thing then I feel also is where the zygoma is. So as you know, you have this zygoma there, and you have the bony brow there. Those are two of your most important landmarks that you have to feel, because in some, particularly in some women, you find the sort of the brow hairs up here, and then you think the brows are there, but they're actually, the bony brow is here, and that's because your orbicularis muscle goes around that. So as you can see, what we have done here is it projecting reasonably well there? Okay, so identify the midline, and so if I sort of peel this off, as you will see there, you see what happens is the frontalis is a muscle that comes sort of from deep, basically, and it attaches into the skin, and it's a very much like a sheet-like muscle, and you can see these frontalis fibers there, and there is a little bit of subcutaneous fat here, and what happens is that if you just inject it into the subcutaneous fat, you're not going to get the ideal result. Now in this case, as you go higher up, there is not much of frontalis there, and there's a little bit of frontalis that's lacking here. So you really want to inject those bellies. Now, how do you know exactly where to inject? The important thing is, don't go below the lowermost wrinkle on your forehead. That's one basic rule, okay? Don't go below the lowermost wrinkle. So in other words, if your lowermost wrinkle is here, as you can approximately see there, so don't go injecting below that, stay above that. And generally what you will find is you'll find a wrinkle here, and then there's a wrinkle here, and then you see this area where, and that is actually where the muscle bulk is. So what you do is you take your, let's just take we don't have small needles, but as I said, so yeah, I will just kind of, so what I literally do is, if you're beginning, you can mark them if you want to, but you do that and you go directly there and you inject go about 3 to 5 millimeters below and inject there. So in this particular sort of patient, where you will see there's not much of wrinkling here, I would inject in one area here, one here, similar pattern on the other side, and that is your forehead, and you might want to inject a second layer there. So that is literally the muscle, and that's how the muscle works. Now obviously what I want to show you here is the superior temporal line here. You don't want to go beyond that. Now having said that, there are some frontalis muscles that have a little small extension beyond that, and those you might want to inject, but those patients are the patients who sometimes you injected them and then they say, I've got a little bit of wrinkling here. You have to be careful though, because if you go and inject there, you might weaken the temporalis muscle. Nothing really happens, but it's something to remember. The other thing I want to point to you here is, I think you can probably see a little bit of that line there. Then that's the vascular pattern. Now, obviously, why do we, when you inject the glabella here, not with Botox, but if you start putting a filler in there, why, what is the problem with blindness? It is because these are supraorbital and supratrochlear vessels. And as you know, they come from the internal carotid system, through the ophthalmic artery. So if you inject into them, you can get a backflow that can go into the ophthalmic artery. Next thing is that, it affects the patient's vision. Now, you really have to be careful, and it's not a joke. And one of the requirements that if you're using the filler is you need to have certain things in your clinic, like hyaluronidase, people say that you should keep some GT, and there are regulations. But and always ask the patient, and the blindness has happened anyway from literally soon after injection up to 6 hours after injection. So you've got to tell your patient, if you have any symptoms, report back straight away. So that's the frontalis muscle. So we will next move on to our next muscle. So if you can switch back the video to the so procerus muscle. Now procerus is a very small muscle, okay? It is almost triangular. It's a small muscle, and it is like a really bulky muscle, but it is a very deep muscle. So when you inject here, you really have to go quite deep. And when I say deep, sometimes, in heavy procerus muscles, you have to pinch the muscle and inject deep, and at least inject 10 units into the procerus, 8 to 10 units. If you don't inject, though you think frontalis is a much bigger muscle, the amount of injection that the procerus needs is a lot more than what frontalis needs. And by injecting that what you're doing is you're trying to weaken those sort of horizontal wrinkling, because that's what the procerus muscle does. It, you know, those details are there. I'll just wait for a while for you to. And procerus works in conjunction with frontalis. In other words, frontalis lifts the brows up, and the procerus brings the brows down. Okay. Then you have the corrugator muscles. In other words, in the glabella, you have three muscles, as the books will tell you. You know, one is the procerus, the second is the corrugator, third is the depressor supercilii. Now, depressor supercilii, I can tell you, I've never seen that muscle ever as a single muscle, and I think it's an extension of the medial fibers of orbicularis muscle rather than it being an actual muscle. Even when I do endoscopic brow lifts where we remove the procerus, even with your endoscope with full magnification, you don't see that muscle. So, but we'll come to that. So these are again muscles that pull your brows down, and we will go through those. And what happens with corrugator muscles is they go from the nasal bone area towards the skin. So they come out into the skin here, just medial to the pupillary, mid-pupillary line. So you want to inject this muscle in two areas. One is medially, and you inject it deeply, and I'll show you exactly where we go for that. And then the other one is laterally, where the point I've shown, just medial to the mid-pupillary line. But stay, when you go higher up, stay in the subcutaneous plane, because the muscle is coming into the skin. If you go deep, then you will cause problems with lid ptosis or brow ptosis, you know, because you might hit some of the frontalis fibers, because at that level, the frontalis is very deep. So that is what we are looking at. Corrugator supercilium muscle, as I said, that it's not something that I may want to, but this is so that you understand what the muscles are, and there are various patterns of these. You know, you don't need to remember these. We'll come to the orbicularis muscle. So we'll go back to the cadaver again, and let's just look at these glabellar muscles. And these are the only three muscles, or actually two muscles you need to remember, you know. So if I put that skin back again, okay, and what we're doing here is literally, as you can see, what happens is, that's the area of the procerus muscle here, okay. Now this one here, this bulk here, and I mean, if you want, you can feel it in your own foreheads, you know, that bulk here is the corrugator muscle, and as it comes laterally, you often find a little bit of bulkiness here, and that is where the corrugator fibers are just literally injecting into the skin, okay. So what I do when I inject is I would inject, for example, let's just lift this up a little bit more. Okay, let me show the injection pattern. So what I tend to do is, like I said, you know, showed you there, I would pinch the corrugator. Is it showing there, or is it better this way? So I would pinch it like that, and then I would inject directly into the muscle there, because it goes deep. It is not a subcutaneous injection. Please don't inject subcutaneously there. You will get bad results, okay? So you need to hit the muscle. You need to go deep. You know, you need to go about good 1 to 1.5 centimeters, even if you sort of don't hit the bone, because it's painful for the patient, but, you know, try and go very deep and just inject directly. So that is your procerus. And then for the corrugators, I would pinch the corrugator like that, and I inject there, and that injection again goes quite deep. So it goes sort of like that, okay? Whereas if I pull this out, and then if I'm injecting the lateral corrugator, the injection is literally superficial into the skin fibers, okay? So it is very important, because if you go deep here, particularly in thin patients, and they have very little fat here, what happens is your botulinum toxin can just go down, go through the septum, and hit the levator, and then they get lid ptosis, and it's very hard to deal with, and patients really don't like it. So, just looking at the anatomy again here, we have removed the skin flap, and just raised that flap. Now, as you can see here, I don't know how well you can see, you see this is the fascia that sits on top of the actual procerus muscle, and if I lift that fascia out, I don't know if you can, let me try and show these. Can you see these muscle fibers here? I don't know if it's projecting well there. These are the corrugator, these are the fibers of the procerus muscle. And procerus is in the midline. And the procerus and corrugators actually are very close to each other, and as you can see, some of the fibers are traveling that way, and they end up here. And these are the corrugator fibers here, okay? And that is why when we pinch, I'm pinching here and injecting it. So, I normally inject 5 units. Most books will say 4 units, but, you want to inject 5 units there, 5 there, and possibly 5 here. But here, as we come more laterally, this becomes very superficial, and you're going to inject very superficially in that area there, So that's how you inject the actual corrugators and the glabellar complex. Very rarely, you injected that, the patient, often will, say to you that they have a little bit of pulling of the skin here. In other words, after you injected it, they get a little pull of skin like that. And that is because you have the depressor supercilii. It's a very deep muscle. So for that, you need to go this way and inject into that muscle directly there, okay? Now, that is a little bit tricky, and I wouldn't say if you are a, not an experienced injector, maybe, just reassure the patient and think about as to how you want to do it. But it's pretty straightforward. So, okay, so now the next thing I want to go back, are there any questions at this stage about the muscles? Anyone? Please put your hands up and fire away if you have any questions, because otherwise we will never know, how much. So happy to take questions. Okay. There's no questions? All right. Okay. So we will go to the orbicularis muscle now. Okay. So now orbicularis is a. Can we switch to slides, please? Right. So with the orbicularis muscle, I think it's probably the safest muscle to inject, particularly in the lower eyelid area. Okay, and orbicularis does. There are many patterns of orbicularis. You have what we call as the orbital fibers. You have the pretarsal fibers, and you have the palpebral fibers. So don't worry too much about exactly how the anatomy, but it is enough to say that the lateral fibers of orbicularis, in other words, these fibers here, you can probably see the pointer. Can you see the pointer there? No, I'll point it with this. The lateral fibers of orbicularis here are the fibers that bring the lateral brows down. So what we want to, if we want to get a brow lift, we inject those fibers. Now, the action of orbicularis is to close the eye, as you know. So what happens is, there are some patients who come, they have some wrinkling. One of the effects of orbicularis injection is you're not only actually getting rid of some of those wrinkling and the crow's feet kind of things, you're also opening their eye aperture a little bit better. And, patients really, really like it. You can hardly ever go wrong with orbicularis as long as your injections are just under the skin, not into the muscle itself. So orbicularis has got various patterns, and those are the patterns where we inject. So I normally inject one here. I sometimes go as medial as that, and then I inject more laterally. Where exactly you can see you can feel, and I'll show it to you on the cadaver here, you can actually feel the lateral bony rim and see how laterally the fibers are actually causing contraction. And you can go a little more lateral from that. So normally, if you can see this is put in here for a good reason, because you're just lateral to the actually mid-pupillary line, and you are just on the bony brow, okay? So keep it on the bony brow, just lateral to the mid-pupillary line, and keep the injections in this area very subcutaneous. Here, again, quite subcutaneous, so it's quite important. It's just a technique that you will get over a period of time, and there are many variations, and we spoke about this muscle, which I think is a part of depressor. So, those are the, kind of orbicularis patterns. So sometimes what you find is some patients will come to you and they have these very hypertrophic orbicularis just under their eyelid. In other words, the eyelid, and there's a big gap between the eyelid and the sort of the lower lid. And that is orbicularis hypertrophy. And the only way you can treat it is to put a small amount of Botox into that muscle directly, So, and of course, there are patients who will actually come and pull all sorts of faces, and then they show you these muscles. And then I tell them, look, you don't really walk around like that. So, let's not, because, we can pull any face and make any muscle move. So I think it's something that you have to be careful about. So let's go and look at the orbicularis fibers again. So if we can go to the cadaver once again, please. So I think what I really want you to understand here is this. Again, the anatomy is, in some people you can see it really well, but you can see this. These are the orbicularis fibers there. Now, if you look at I haven't lifted the skin from the upper eyelid area, but, as you go down here, you'll find the skin is sort of thick here, these are orbicularis fibers, but your pretarsal orbicularis is very, very thin. And this is the circular orbicularis fibers, and sometimes you can see how laterally it extends. It extends up till there. And if we can actually then go down here, you can see those are the sort of vertical fibers of orbicularis that come there. That's the bony orbital rim, okay? Now, in this particular patient, I've peeled a little bit of the muscle from the bony orbital rim, but you don't, so when you're injecting, I inject directly into the bony orbital rim here. And sometimes what happens, you inject it there, yes, the books say, yes, I'm saying just inject in that area. Sometimes the orbicularis actually spreads out a little bit more, in which case they have these wrinkles that are going down, but those wrinkles are going that way, they're going towards the ear, they're going towards the pinna, and then you can inject it here. But if those wrinkles are going down that way, that means it's related to the activity of your zygomaticus muscles, which we will come in a minute, and you don't want to inject it on the zygomaticus or zygoma as such. So those are the lateral orbicularis fibers. Now, if I lift the skin up here, you can see I've lifted up the skin here from the eyelid. There's only skin. That is a fat which is deep to the septum, but actually the orbicularis muscle that is here there's very little fat on top. So when you're injecting here, you want to literally inject in the subcutaneous plane, literally under the skin, In other words, you should really see a little blob, of your product going in there, and, it's injected there. Now, we will talk about the fillers in a minute, but if you're going to inject the tear trough area, this is where we are injecting, and you have to feel the orbital rim to make sure you don't actually inject into the orbit itself. So orbicularis, injections actually very straightforward. They don't cause any problems, but just be careful not to inject too deeply, So that's about the orbicularis. Let's see what else we have in terms of the muscles. So the nasalis muscles, as you know, there are various parts of the nose. Now, one of the things I often see in my patients is that they want a rhinoplasty because they feel the nose flares up too much when they smile. Otherwise, the nose is absolutely fine. And these patients actually you can deal with, without surgery, because if you try and make a nose smaller in a patient where the problem is only flaring, on smiling and on animation, I would say you're not going to get a great result. You'll get a reasonable result. And what happens is that if you actually, think that you can, divide the muscles and you do that, then what happens is you can get nasal obstruction. We talk a lot about, patients getting nasal obstruction following rhinoplasty from medializing and things like that. But if you actually look at the anatomy, often it's not medializing the whole thing. Yes, medialization is a big problem, I think, but there is also a component of muscles that actually flare your nostrils out, that don't give you nasal obstruction, particularly when you're exercising and things like that. So, and I think it is important. So we will be looking at the nasalis muscles. There are various fibers of nasalis, as you will know. Some of them actually pull the nose in the upper lateral cartilage area, whereas the alar nasal fibers actually pull it slightly out. So these are the fibers that you can deal with botulinum toxin. Now, one of the things I do in some of my patients is that if they have had surgery to reduce the flaring, I do the surgery, and at the time of surgery, I do put about 50 units of botulinum toxin on each side. And that is because what happens when you put botulinum toxin, a large amount, is simply some amount of muscle atrophy. And that muscle remains atrophied for a while. So I think it's a good trick to use. It's the same thing with scar revision. If you're doing, scar revision surgery, always use some Botox. And also remember, botulinum toxin not only just improve your, muscle, lines, they also improve the, skin quality as well, and it's a well-known fact. So I will go through one or two muscles around the nose in some detail, and then we'll go to the cadaver again. So this muscle, it's a very tiny muscle. You can see it really well. This is the muscle that causes gummy smile. And the other thing that you often find is when a patient has got a hyperactive levator, in other words, it's pulling the lip up, and these are the patients who also have a depressor septi that is also very active. So it's a combination of the tip moving down and then, rest of the upper lip going up. That is the problem. And those, you can fix it with the botulinum toxin, but some of these surgeons really need surgical intervention, now we will just go through these muscles. Depressor septi, I haven't dissected. I couldn't see it in this patient, but sometimes you may have to inject that muscle as well. So just going back to the cadaver here, so again, it's important that you remember your anatomy, feel the bony prominences. And why do I keep saying this, feel the bony prominences? Because I think it's a habit that you need to really get into to actually understand how these things work, So, so if you're looking at the nasal fibers, so you can see the nasalis muscle here. So when this contracts, these fibers contract, it pulls everything in here, okay? And these are the fibers, the alar fibers that pull it out to a degree. So when you inject this, you actually get loss of flaring. And you can see this. Now, what happens when we do rhinoplasty is, of course, we are actually elevating this because we are right on top of the cartilage. So here what I've done is, I'm pretty much in the supraperichondrial plane, in the subcutaneous plane almost, Now, again, if you do enough rhinoplasties, depending on what sort of rhinoplasty patient you're dealing with and what the problem is, your skin elevation or your elevation of the SSTE or soft tissue skin envelope depends on what you want to achieve. In some people, I would go subperichondrial, some people I will go supraperichondrial, and some people I go above the SMAS layer. So it's very variable. So, these are the muscles that you can inject. And how do you inject these? Literally, if I'm going to inject this, there are many patterns here. Sometimes you see all the wrinkling in this area here. And when I see that wrinkling, I inject directly into those wrinkles. So what I tend to do is I hold and I just go and inject directly into the muscle. It's very superficial, so be careful not to go too deep. But if I see a wrinkling here, then I go a little bit here and then I inject here with my bevel needle down. Same thing on the other side. So that is injecting nasalis fibers. The levator labii superioris echinacea is the muscle that originates from here, and we might be able to see some of the fibers coming up there. I think you can see them here. I don't know if you can appreciate them. You can see that they're going all the way down and they're coming up from here all the way up here. Okay, and that's the one that makes the gummy smile. So the origin of the muscle is really in this area, and if I look at that, it's actually here. So as I showed you, when I inject, all that I do is I put my needle here, you hit the bony edge here into the piriform area, and you're injecting there. So that's the injection of that muscle, and it is only one injection. Don't go on injecting here because you'll cause other problems, One thing that you have to remember is there's so much interaction between muscles. Every time you inject one, something else happens. And I think as you get more experience, you tend to understand what is happening. And then I just wanted to show you one thing here was that, if, as I was talking, if you look at it, the crow's feet area is here, and then you have injected here, so the patient is happy with crow's feet, and then they come and tell you, I'm getting some wrinkling here. and this is very important, is, when you inject there, and that wrinkling is because of this muscle. This is the zygomaticus major here, okay? Zygomaticus major is a very superficial muscle. So, and you are going to, if you think that by putting here, you're going to get rid of the, you're injecting right onto the zygomaticus major. Patient is happy for 1 or 2 days when they don't see that wrinkle, but suddenly they realize that the corner of the mouth is just not moving. It's like they just look sad all the time, So then, so do not inject that muscle, and that's why you saw in my photograph there that I had put, avoid that area. So, so that, and then, the masseter is further down here, as you can see. As you know that we do inject masseter for mesenteric hypertrophy, and I think it's a good treatment. For patients with bruxism, who, it works very well, but then again, you need to understand why are patients getting bruxism. It may not be often, just related to, it could be their dental status and various things like that. So that is pretty much, a very quick tour of the, anatomy of the, that is relevant to Botox. Around the mouth, as I said, I was talking to you about injecting the upper lip here. You can often you can see when the patient is animating, you can see those wrinkles forming. But one thing that I would advise is that if you're injecting, don't inject high up in the lip. Because if you inject high up in the lip, the Orbicularis oris muscle actually has got various layers. And when you inject higher up in the lip, what happens is that the lip looks much longer. So if a patient already has a long lip, those lips will look even longer. So you really want to inject further lower down, So, and I will just go through some of the mentalis patterns in here, though we haven't dissected those. If we can switch back the video to the, okay. So, as you can see, Orbicularis oris is a muscle, and one thing to remember is it is a complex muscle, and particularly the lower lip. Often patients will come and pout their lower lip and they'll say, oh, look, I've got these wrinkles. And I think injecting the lower lip is the worst thing that you can do, because next thing is they're drooling everywhere, so just don't inject it. So upper lip is fine. You can occasionally do the lower lip, but you really have to be experienced. And there are various fibers of it. You need to really understand the muscle. I think there's a full book chapter I've written on, how the orbicularis works and things like that. And then, as you come down, it becomes more and more harder as to what you inject, except, for example, let's see, depressor anguli oris we spoke about, where we inject the muscle. The one from the anatomic point of view, how do you find this muscle is pretty, pretty easy to find. Ask the patient to clench their teeth. You feel the masseter on the mandibular border, and you just come about 5 millimeters in front of it. That's where your DAO is, depressor anguli oris. Now, if you are good in injecting, you can inject it just here where the muscle takes off and where it comes down. But if you're not sure, then just do what I asked you to do. Ask them to clench their teeth, feel the muscle in front, just inject about 4 to 5 units on each side. Mentalis is the muscle that causes chin puckering. There are various patterns of mentalis, and you can see these patterns here. And how do you know these patterns? You can see when the patient is talking and smiling. Now, most patients don't actually, tell you about the mentalis problems, but if you point it out to them, they actually see it. And if patients have a deep groove between the, like a labiomental fold, a very deep labiomental fold, it's worth injecting mentalis. Masseter for mesenteric hypertrophy. Patients who have TMJ problems, it works very well. You may have to inject in multiple areas. I sometimes inject up to 50 units on each side. These have to be very deep injections with very, very good results, and the hypertrophy goes away. But in the meantime, you also need to deal with, patients, why it is a problem for the patient. Now, if you see a patient who has got significant mesenteric hypertrophy, and they also have temporalis hypertrophy as well, temporal muscle hypertrophy, then you have to think about dental occlusion, and because you know that the whole of the masticatory area is actually causing problems there. Right, so that's a little bit about the platysma we spoke about, very superficial muscle, hold it into the skin, various patterns, look at it, and then inject the areas where you inject. With platysma, you have to have multiple injections, not 1 or 2 or 3, depending on how much, platysmal banding you get. You will have to inject maybe 5 sites, 10 sites, 15 sites, and things like that. And there's a lot of things, and this is just a very kind of quick, kind of thing to say that do not inject these zygomaticus muscles. Just briefly, before I finish, I'm going to talk about the fillers. Are there any questions at this stage?
If we perform Botox for CrossFit,
Yeah.
and we have some deformity in the upper part of the orbicularis, can we use filler, or it's
No.
not the right way of thinking?
No, yeah. Do not put fillers unless and until you are absolutely an experienced injector and know the anatomy. Don't fill the eyelids. Okay, it's very difficult. Personally, I don't use fillers for the eyes, for the eyelids. I do fill the eyelids, but I use patient's own fat, Even that, the patient has to really get a hammer and threaten to beat me up to do that. In the sense, I'm very, very careful. It's a menace.
Do you have any experience with injecting PRF or PRP?
PRP, we use all the time, is brilliant. Completely another subject, unfortunately. I could talk about it for another 2 hours. But PRP is absolutely the right thing to use in those areas. One thing about PRP, for anyone who don't know what PRP, it is platelet-rich plasma. In simple terms, you take 50 mils of patient's own blood, put it in a centrifuge it, you get about 2 mils of platelet-rich plasma, you get some platelet-poor plasma, and you get some fat and some, red cells, white cells, but you inject the platelet-rich plasma. It's got lots of nice growth factors, and they get some very nice results. The funny thing about PRP is that when I've injected, and we do that quite often in patients, I don't see a change very much myself, but patients are very happy. They feel that their skin, texture, their skin, everything has changed. So if there's one thing that, apart from Botox and fillers, yeah, absolutely. And at least you don't have any problems, It's just a little more expensive, but it works extremely well. Yeah. So, fillers. So very briefly, and the first thing to say with fillers is fillers are really, really nice for facial rejuvenation. I use fillers, as I said, not in the upper eyelids or lower eyelids, but I use fillers for the tear trough, I use fillers for the glabella, I use fillers for the nasolabial folds, for the lips, but the important thing is how do fillers interact with your vascularity, and I think you need to really understand the depth of your vessels, what they do, and there's a lot of debate about when you put a filler, do you actually aspirate or don't aspirate? That is the big question. Now, I've been on many, Zoom forums, and we have this massive argument between the aspirators and non-aspirators, and I think it was on a live podium. We'll probably punch each other, but anyway. So I believe that aspiration just doesn't work. I don't know how it will work because it's very hard to aspirate because it's very precise injections. So what I believe is that you really need to watch where you're injecting. You need to look for that change. You need to see what is happening and move your needle, micro movements all the time, when you're filling. Now, recently I was on a forum and somebody was talking and he was saying, oh, I use this ultrasound device, probe. But then, how are you going to inject and use the ultrasound probe? And I think it's a bit of nonsense. So I think it just doesn't work. In my opinion, I'm a non-aspirator, but I think you really have to be careful. But you really need to understand the vascularity. And more important is to understand that if a patient has had previous surgery, previous filler injections, you can get more problems. So be careful. The other thing is also important to remember is the problems, particularly skin necrosis from fillers, is not from injecting intravascular injection. It's from the local injection causing pressure locally. Now, what happens is that most of the fillers, before you inject the filler, if you read what the filler has in there, the filler also has some epinephrine, a lot of these fillers. They also have some lignospan, some of these fillers. So there are various things that our fillers are, combined with, and I think it's important to understand. Now, what happens if a patient has some amount of, let's say, xylocaine in fillers? As you know, that the xylocaine causes vasodilatation as soon as it goes in, and after some time, you get vasoconstriction, and that is how the local anesthetic works. So what happens is if you put a large amount of filler, the very action of putting the filler, as you know, as soon as there's vascular trauma, you get vascular spasm. And to top of that, after about 20-25 minutes, you have this perfect combination of vascular spasm, your xylocaine-induced vasoconstriction, and then often patients putting ice on top of that, okay? So you have 3 factors that cause that vascular compromise. And I think it's very important to understand that, and I think it's very important to tell the patient. Now, I know if you read articles, people talk about injecting, 10 mils, 15 mils. I would say in my practice, the maximum I've injected is probably about maybe 4 syringes, which is about 4 to 5 mils, and that's about it. But if I'm injecting the lips, as I said, it's less than 1 mil. So keep it to the minimum, So the facial artery is probably the most important artery that you need to understand. Yes, textbook course, is very standard, but it varies significantly. It varies on how much pressure you're putting. It varies on the skin type of the patient. It varies on the subcutaneous fat. So, remember all these things, before. And this is what I needed to understand is facial artery, then there is a communication between the, nasal arteries, supraorbital, supratrochlear arteries, and all of these actually they all feed into the internal carotid system, and I'll show you some pictures. Now, angiosomes, you don't particularly need to know that. Just, I'm jumping into the danger zones, okay? So, the danger zones are these. I've just classified them. This is from Allergy, so, these are, so basically what happens is, the supratrochlear, supraorbital areas, the glabella is a real danger zone. But it's very simple if you can just remember that your wrinkles are in that area there. You have put Botox. So if somebody has got very deep wrinkles, put some botulinum toxin first, wait for about 2, 3, 4, 5, 6 weeks if you want to, till those wrinkles flatten out a little bit, and then go and put the filler in, okay? So don't jump into the filler straight away. So as a result, I always say, your neuromodulation is always first, followed by the filler injection. So what you do is the blood vessels there are very deep, okay? So if you stay in the subcutaneous plane, you are not going to get into trouble, okay? So just stay in the subcutaneous plane. You can't do any harm in that. So, but the bigger problem comes when you go laterally, when you do temporal fillers, and I'll show you on the cadaver how it works, So I'll finish this whole series and then I'll go to the cadaver as a last thing, So laterally, when you're filling in the temple area, be very careful. Now, I always say to people, fill in between the layers of the superficial and deep temporal fascia. Now, people ask me, how do I know where I am? Frankly, I don't know either, but I feel when the needle just gives way, I'm in that right plane. Maybe, I do, temporal facelifts all the time, so I know where the layer is. And, most of us, if you've done enough surgical work, particularly, fixing, perforated eardrums and laryngoplasties, we probably know that where this, areas are. But again, you see, this is a major, major problem for blindness because you have a very close, intimate relationship with the internal and external systems. The third zone area, and the areas that I mentioned literally go in terms of the frequency. Glabella is the worst, followed by the lateral temporal area, followed by the nasolabial fold area. You think it's very easy. Now, one thing when you're injecting the lips, that you need to remember that the vascularity is on the oral surface. In other words, it's closer to the mucosa. So if you stay on the skin surface, 2 to 3 millimeters from the skin surface, you're generally safe. And this again, the same thing. And when you're injecting the nasolabial fold, again, it's the artery. The facial artery is the problem. Now, the facial artery here, further down in the lip, as it's just going up, it's quite deep, So staying subcutaneous there is not a problem. But as you come towards the sill, the nasal sill, the nasal alar area, the artery is very superficial there because, as you know, it rises up into the lateral nasal wall. So what happens there is that the artery is very superficial. So you can do two things. Either you can go very superficial, in which case it's quite painful for the patient, or you can go quite deep. You know, where you go is your choice. I mean, I tend to stay quite superficial in that area because I find it's easier for me to control how much I'm putting, because if you go deep, then you have to inject more. Okay, so important to remember. So try and, you know, get that in your head before you do that. So whilst we're injecting, there's what we call as a fern pattern. I think it's a very nice way of injecting. In other words, you know, one of the misnomers, particularly in the nasolabial fold, we actually say inject the nasolabial fold. It's actually the crease we are injecting. So with fern pattern, if you inject on either side of the crease, not directly into the crease, but very close to the crease, it actually tenses the whole thing up, you know, and it works very well. But of course, these are multiple small injections. And we've just spoken about that. And finally, the nose. You know, I think that nose blindness is not a problem here, but it can be. But the bigger problem is skin necrosis, and we see enough of patients with this. Dario Bertozzi, who's a very good friend of mine, who's probably one of the most proficient injectors from Italy, he shows me a slide, a case series of his practice nurse whom he injected, and the skin started going blue in the nose, and then he said for 1 week he had completely sleepless nights. She settled fully, so it is worrying. So yeah. So blindness, why does it happen? It's a sort of, this is mainly, it's a supratrochlear, supraorbital, dorsal nasal artery connecting with the ophthalmic artery. And if you want to remember something, you want to remember that, it does cause blindness. So do warn your patients about blindness if you're using fillers. Finally, these are the, this is how it all works, So if I just go back to the cadaver, and I think we won't need these slides anymore. I think we're done with that. So I'm just going to go back to the cadaver for a few minutes. How are we doing for time? Okay? Right. And then we can take questions after that. And then we can show you a little bit of nasal anatomy if necessary. So, so as you can see, we were earlier dissecting here. Now, in an injected cadaver, sometimes you can see the vascularity very well. But what I have done is I've almost done a rim incision, which you must never do, I must say, in the nose. I don't know if you can, we saw it earlier. Okay, so here's the fat of the nasolabial fold area here, okay? So if I go into that fat area, I don't know if you can see it well. Can you see that vessel coming up there? Are you able to see it at all? This one here. Now that is the, sort of the branch, angular branch. So that's a branch of the facial artery. Now, as you can see there, it's quite deep here because you have the fat, but as it comes up here, it becomes more and more and more superficial. And then it literally becomes very superficial here. And then it actually hits the angular vessel pattern here. So these two, so if you're injecting anyway here, you can get, blindness related problems here. Not common, but you can get that. Now, if we go to the temporal region here, as you can see here, you see what I've done is that's the superficial sort of fascia. Some of the galea has gone with there. And then we have this superficial temporal fascia. Now remember, when we are doing that, for example, when we're doing a facelift procedure, your branches of the facial nerve are in this layer here. So you got to go fairly deep, but that doesn't apply to fillers. But and this is the temporoparietal fascia that you're seeing here. As you can see, that is a layer of temporoparietal. And see, it's nice thick fascia. And usually, I say if you're going to inject a filler, that's almost an avascular plane there, okay? So now one thing to say is that if you're injecting a filler and suddenly you feel the temple is just filling up, just stop straight away and put lots of pressure, put proximal pressure and distal pressure, and just, if necessary, even put some hyaluronidase to stop the spread from it. It never has happened to me, but I always feel that you always have to think about what you're going to do. It's not a matter of pressing a button for help, but it's a matter of just acting very quickly. So what I tend to do is, my needle, generally speaking, goes sort of, if I'm injecting the temple, it goes in there and it literally stops when I see that. And, I'm not quite sure if you can see it very well, but it literally actually goes through the skin, through the temporal parietal fascia or the superficial temporal fascia, which is there. And as you know, that the facial nerve branches are running in there, and I think you might be able to appreciate some of the vascularity there as well. And then you have the deep temporal fascia there, which I have dissected, and then you have the temporalis muscle. Now, some people talk about injecting the muscle, because for me, injecting the muscle, I think, should never be done, because it causes muscle trauma, then you're damaging the muscle. It's just like bruising a muscle, who wants to bruise a muscle? So I really want to inject in this plane here. And how do I inject in this plane to be safe? I don't use multiple puncture techniques here. So what I do is I inject a small amount there. So I go in, I inject if I don't see anything, and then I just literally massage it around, because it's very easy to massage it around. Because if you move your needle too much, you are damaging the temporal pad of fat, which is one of the reasons why people get excessive hollowing in that area. So you can see the anatomy really well there. So that's the area that you're going to inject in, and it is a very safe area. So I think that is, pretty much the anatomy. And as you can see, when we are injecting the glabella here, for example, as I said, the wrinkling is sort of superficial. If you inject superficially, you're literally injecting into the superficial pad of fat. The vascular pattern actually comes from quite deep down. So you can often feel the orbital supratrochlear notch here. And let's see if I can show you. In an injected cadaver, it's much easier, and when you're operating on the patient, it's even easier to see these. So you can see that vascular. Can you see those little things there? I don't know how well they're projecting, but that is where it's coming up from. So, these are very consistent areas. So if you feel the orbital rim, feel for your notches, feel for bony landmarks, those are your guides. It's a bit like finding the facial nerve, really, So that's the very basic anatomy as applied to botulinum toxins and fillers. So I'm going to stop at that, and we opened up the nose a little bit if you all want to see anything in the nose. But so just to give you a brief anatomy of the eyelid here, and I think I might just... Have you got about 5 minutes to do the eyelid anatomy? Okay, so you see what happens is the skin is very, very thin, and then you have the orbicularis muscle, and once you've gone past the orbicularis muscle, you see the fat, and actually this here is what we call as the orbital septum. And if you remove some of the septum, what you find under the septum is more fat, and this what you're seeing is the orbital fat. And what happens is, if your injection goes too deep, then the injections are going to go through that fat, and it'll actually affect all the muscles in there. And that's why some people who had Botox will, I've had a patient who was sent to me, young lady who was sent to me saying that, I think this patient needs a blepharoplasty because her whole brow was down like that. She was only 27, but the problem was Botox, and the treatment was just wait for 6 months, So, okay, so that's pretty much any questions? No?
First of all, I want to thank you for the enormous effort you put in preparing, scheduling, and doing all this dissection. I think it was one of the most thorough dissection courses I've ever attended. And I just can't imagine what they're going to charge in the USA Congress for a Congress like that to the participants. Anyway, any questions? A lot of information, difficult to digest.
Yes.
Oh.
I've never met this lady before.
So thank you very much for the excellent presentation. I
That's
wanted
fine.
to ask, if you were to inject, let's say, off-license post-rhinoplasty, let's hypothesize you had a patient who had a rhinoplasty, you took the hump down, they present 6 months post-op with a bit of wrinkling in the area between the upper and lower lateral cartilages. Let's say you had this case. Would you prefer injectables? If yes, what? And how long do they last?
Did you say wrinkling? Anesthesia?
Yes, when they smile.
Smile.
They have a bit of wrinkling.
Yeah, I would inject Botox. You know, what I would do in them is I would inject about 5 units of botulinum toxin in just one area where the maximal wrinkling is. And generally speaking, what you're doing there is you are treating a small volume of the muscle with a fairly, high dose of Botox, and that muscle just atrophies. Usually, that's it. They don't, sort of come back.
Thank you very much.
So,
Thank you.
sorry, we work together. So,
It was pre-scheduled, I know. Any other question? Yes,
any other questions?
gentleman there.
Hello, thank you for the presentation. To what extent does skin thickness and quality affect the results, and how would you adjust your technique accordingly?
Skin thickness, look, I think skin thickness, it does certainly affect it. Because in very thick skin people, if they already have fully formed wrinkles, you can put botulinum toxins, you can put fillers, you're never going to get a good results. That is when you have to think about other options, like how do you deal with the skin. Now, one of my other interests is dealing with the skin, So I also work with dermatologists. So what we tend to do is we treat them with tretinoin to reduce the skin thickness for some. They might need lasers and things like that, yeah. But, one thing to say is true, is that patients who have very heavy sebaceous skin, if you inject dilute amounts of Botox in the subcutaneous plane into the skin, that skin looks a lot better because, again, the botulinum toxin, there are lots of studies to prove that it actually works as an anti-sebum because it works on the acetylcholine, receptors, so they get less of it. So, say, for example, very thick, oily skin, you can do subcutaneous, or just intradermal Botox, but you really have to have some experience as to how to do it. But, but I wouldn't exceed the doses that I've used generally to actually deal with that, because you're not going to get any better result. As soon as that happens, you've got to think about what else is happening. Yeah.
Thank you very much for this class. My question from medical legal issue. Do we have to consent patient before the injection or not?
Yes. Every single patient, I think I don't do anything without consenting the patient. I do everything on my iPad. So every time they come back, Botox patients, I consent them once in 6 months, but filler patients every time because of the blindness and skin necrosis issues. Can I just borrow you for a minute? Just wanted to thank you for your help because, we spoke about cadaveric dissection. I think without you, we would have never been able to do that, because I think you were the master, trying to help me, and I was trying to learn endoscopic sinus surgery from him whilst doing the dissections. Thank you very much.
One final remark. I think that you've mentioned before, and I want you to emphasize that you are not advocating liquid rhinoplasty at all.
Sorry, say
You
that.
are not advocating liquid rhinoplasty at all.
No, I'm not an advocate of liquid rhinoplasty at all as a just primary treatment for every single patient that comes to you, because the problem I find is it's marketed so heavily. I mean, you look at Instagram, you look at Facebook, you look at, people talk about liquid rhinoplasty. But I can say one thing for sure is any patient who comes into my office, what we tend to do is this. If the patients ring my office and say, do I do filler rhinoplasty? The answer is yes, we do. But by the time they leave the office, they go for proper rhinoplasty. Yeah. because every single rhinoplasty I do morph the patients. They do get their photos, so they can see what the change is, and they know there's a permanent change. But the short answer is, I think there's a place for it, but not as a, yeah. Sorry.
Any
Thank
other
you.
question?
Yes.
Yes.
Thank you very much for your time. I've had the opportunity to observe some of the facial reconstructive surgery with Mr. Andrews in London. And
Yeah.
I wanted to ask, is there a role for the use of Botox injections almost as a rehearsal before a permanent surgery in facial palsy patients?
Yeah, Peter Andrews will tell you yes, because I've told Peter, I always say to Peter Andrews, always trial it out, always, because it is not just for that, it's also for balancing the patient's post-op. It's when they get this synkinesis and things like that, you know. There is, I think Botox has got a huge role in you know, doing, and there's a course I run with Peter Andrews, you know, once a year, we talk about this. And yes, there is a very, you know, I mean, there's definitely a role. And in fact, I have patients who have mild weakness on one side, they just come to have their face balanced. Absolutely.
Thank you very much.
Thank you.
Again. Sincerely, thank you for your help.
Right, so go and have a nice cup of coffee and tea. Thank you.